Good morning, everyone. Thank you so much for coming back. We have already finished the previous 4 lectures, and today this will be our last lecture of this academic year. We have seen this outline for multiple times. This lecture we will finish our last section, which is the bullous disorder. Also, we will spend a little bit time to talk about the congenital disorders that can cause bullous formation. Let's get started. I hope you still remember this big picture, and today we finally reached the hours number 9 intraepidermal and number 10 subepidermal. First, let's use this example to demonstrate the structure of the skin. Everybody can see this is a cross-section of a house, and everybody knows that in order to have a very steady house, we need to have a strong foundation as shown here. But also, we need to have the wall made by the bricks. So this is the skin. We use the similar concept. The epidermis, just like the house, need to attach to the dermis by the foundation. And the foundation is the same function of the dermo-epidermal junction. Also, we have the keratinocyte in the epidermis, which is the same concept or same function as the bricks, which are used to build the wall. Furthermore, when we build the house, we use the cement to attach the bricks. What should we use to make the keratinocyte attach to each other as well as attach to the basement membrane? The answer should be 2 ultrastructures. The one on the top is the connection between each individual keratinocytes. So this is the desmosome, and the one in the bottom, this is the hemidesmosome, to make sure the keratinocyte can attach to the basement membrane firmly. When we keep zooming in to see the desmosome, we have this structure. Left and right, those are the 2 keratinocytes. In the structure, you can see there are multiple different small structures, including the desmocolin, desmoglein, plakophilin, desmoplakin, and those are very important to maintain the function of the desmosome. If one of the function is compromised, there will be a function issue with the desmosome. And this is the ultrastructure of the hemidesmosome, which as a function to attach the keratinocyte to the basement membrane. And you can see the hemidesmosome is composed of different structures as well, including the BP230, BP180, laminin 5, alpha 6, and beta 4, as well as some anchoring fibers, which is composed of collagen type 7. Not only those structures, you also want to pay attention to 2 layers as well. The first layer is here, demonstrated as the lamina lucida, and another layer is below the lamina lucida, which is the lamina densa. Pay attention to those names. Those names will be mentioned in the later lectures. So first, let's talk about the part 1 of this lecture, which is the bullous disorder. And we know in the bullous disorder, we can subdivide them into intraepidermal as well as subepidermal. When we subdivide the intraepidermal category, we got the pemphigus vulgaris, pemphigus foliaceus, paraneoplastic pemphigus. And similarly, if we subdivide the subepidermal category, we got the bullous pemphigoid dermatitis herpetiformis, linear IgA bullous dermatosis, epidermolysis bullosa acquisita, porphyria cutina tarda, as well as paraneoplastic pemphigus. You may have noticed that I put a star here as the paraneoplastic pemphigus has overlap features between the intraepidermal as well as the subepidermal. Also, in the later lecture, I'm not going to repeat all the long names. Instead, we will use the abbreviations here: PV, PF, PNP, BPDH, LABD, EBA, PCT, and PNP for short. That is very common when the names use a lot of Latin words, and we use abbreviations more commonly. So let's further go to the intraepidermal category. The first disorder is the pemphigus vulgaris. As you can see here in this person, the skin is composed of many moist erosions. Those erosions used to be some flaccid bullae. Because the bullae, they are so fragile, whenever there is a friction between the skin and the cloth, those bullae, they just ruptured. Also, there is a positive Nikolsky sign. What does that mean? Basically means some of the skin, when they are erythematous looking, and if you push the skin with your finger, the skin shears very easily to show some ulcer as well, or erosion as well. The characteristic feature in this PV is the involvement of the mucosa, and usually they also presented as erosions as well. And the common affected age are older adults in their 50s and 60s. Also, since it is autoimmune disorder, it can be associated with other autoimmune disorders such as MG or thymoma, etc. What is the pathophysiology of the pemphigus vulgaris? The etiology is that the body is generating all those autoantibodies against the structure in the desmosome. We call the desmoglein, which is demonstrated here in the circle. And we have two major types of pemphigus vulgaris. One, the autoantibody only targeting the desmoglein or DSG-3. The other subtype, the autoantibodies against the DSG3 as well as DSG1. There will be further explanation to demonstrate the difference between those two. But at this moment, I hope you can remember the main targeted desmoglein is the number 3. Number 3 is the most important one. Because of the damage to the desmoglein, the function of the desmosome got disrupted and causing the acantholysis between the keratinocyte. And because of that, we further understand the histology, which is the intraepidermal separation of the keratinocyte and forming this blister. And the split is just above the basal layer, left over 1 or 2 layers of the basal keratinocyte. And the structure of the leftover papillae, as well as the 1 layer of the basal layer, demonstrated just resemble the tombstone. So people call this tombstone sign. And in the past, historically, the death rate before the usage of the steroid can be as high as 90%. So at that time, people, whenever they see this tombstone sign, not only they are implying the morphology of this H&E, but also they are referring to a very high mortality rate. Almost they are seeing the tombstone in a few months. And also another feature is the pemphigus vulgaris can have many inflammatory cell infiltrate, and predominantly eosinophils and even forming some eosinophilic abscesses. Before we go into the actual direct immunofluorescence result of the pemphigus vulgaris, I would like to spend 1 to 2 minutes to explain how we perform this immunofluorescence assay. We actually have 2 types of immunofluorescence, direct and indirect. I think at the APCP level, understanding the direct immunofluorescence study for diagnosing those autoimmune blisters is more important than the indirect one. So we will mainly focus on the DIF, direct immunofluorescence. And why we call direct is we directly using the patient's skin. The biopsy of the patient's skin will be cut into the microsections and placed on the slide. And then in the lab, we got our reagent. The reagent is actually an antibody, not the patient's antibody, but antibody designed and manufactured in the lab. The antibody will have attachment to the fluorophore. Another enzyme can shine a light under the laser. And then we got this antibody and place it on the slide. We understand there is a patient's skin. If this antibody from the lab can attach to anything, any antibody on the patient's skin, there will be a signal. That is the positive direct immunofluorescence study. I hope I explained that better. And when we have a signal, how we read that result? We read them under the immunofluorescence microscope, and we look at different slides. One slide has IgG, the other one should have IgA, IgM, C3, fibrinogen, etc. And then based on those slides, we give them a report of a positive or negative result. I think if you have already had your rotation at Children's Hospital looking at those renal biopsies, you should be familiar with this technique already. But in the skin, we also demonstrate what is the shape of positivity. Is that linear or granular? Is that IgG positive or IgA positive with or without C3? Those can make a difference in making the diagnosis. With the two questions I wanted you to ask yourself, we can try to interpret this direct immunofluorescence picture. And you can see the deposition is at the epidermal side. And the epidermis is showing those net-like pattern of positivity. And the second question is, what are the immunoreactants? And let me tell you, this could be either IgG or C3. It doesn't matter. It has to be one of those. So we have that combination of net-like pattern IgG plus C3. This is very characteristic for the pemphigus family. And why I say pemphigus family, because there will be more pemphigus in the next few slides. We will continue the pemphigus foliaceus, then come back. Next disorder is the pemphigus foliaceus. It is the sibling of the pemphigus vulgaris. Foliaceus means falling leaves. Vulgaris means regular, just like the acne. Vulgaris means common or regular acne. So pemphigus foliaceus, the clinical presentation is slightly different from the pemphigus vulgaris. Instead of big erosion and flaccid bullous, this one, the blister is even more fragile, left over only erosions which are crusted. And if you try your finger on the erythematous area, you will have a positive Nikolsky sign. It has a particular distribution in the seborrheic area, such as head and neck, and the back, the chest, and the groin area. It is very pruritic, and important feature to differentiate the pemphigus foliaceus from the pemphigus vulgaris is the PF. It does not involve the mucosa. I will explain why. In terms of the pathophysiology, the pemphigus foliaceus, instead of targeting the DSG3, it is targeting the DSG1. So because of that, the separation is different. Remember, the pemphigus vulgaris, the separation is suprabasilar at the deep aspect of the epidermis. Instead, the pemphigus foliaceus, the separation is just below the cornified layer and just at the granular layer, causing this acantholysis. And that is the reason we don't see the flaccid blister very often, because the wall of the blister is too thin to even maintain the shape and the fluid inside of the blister. Very, very easily got ruptured. The differential diagnosis of this one is the 4S, the Staphylococcus gout skin syndrome, because this one also has a separation at this layer. But when we perform the direct immunofluorescence study, we can tell those two disorders very easily. The 4S syndrome, the 4S, it does not have a positive IgG. Instead, the pemphigus foliaceus, you will see this net-like deposition of the IgG within the epidermis. It's all the same pattern as the pemphigus vulgaris. So now you should ask yourself, if you have this pattern, what should you do if you don't have the clinical information? And the answer is we look at other features. If there is involvement of the mucosa and the histologic feature, if the split is above the basal layer or be just below the subcorneal. But also, not only we want to know this feature, we also want to know why those two disorders present differently. The reason is that in the pemphigus vulgaris, the targeted desmoglein is either DSG3 only or is a combination of DSG3 plus 1. In the pemphigus foliaceus PF, the targeted antigen is only the DSG1. And you are asking further why it make a difference. Let's further explain why we have the different presentation of the PF and the PV. As depicted here, we have a demonstration of a skin structure from basal layer to spinous layer. And here is the component of the skin desmoglein 1 and desmoglein 3. People realized that in the normal skin, we have more heavy DSG1 on the top with more heavy DSG3 at the bottom. That is the situation in the skin. In contrast, the mucous membrane is a different story. We have both DSG1 and 3. However, the DSG3 is much more prominent in the mucous membrane. That is the fact number 1. And the researchers found a factor number 2, which is if there is a loose function of the DSG1, missing DSG1 can be covered or compensated by the intact DSG3. However, the DSG1 cannot compensate the missing of the DSG3. That is the fact people found as number 2. With that in mind, let's go to the next slide. Now let's talk about disorders. In the category of the pemphigus vulgaris, remember we said there can be two combinations. The combination number 1 is the autoantibody only targets the DSG1, or it can have a combination of DSG3 plus DSG1, and we give them different names. If the autoantibody only targets the DSG3, we give a name as the mucosal dominant pemphigus vulgaris. If we have a combined DSG3 plus 1, we give a name as the mucocutaneous pemphigus vulgaris. And let me explain. In the mucosal dominant or the DSG3 PVs, when there is an autoantibody against the DSG3, which is killing the DSG3, and we demonstrated with this red little triangle. And remember, we said the DSG3, which is demonstrated in green, the green can cover or compensate the missing of the DSG3. That is why the skin is still intact, okay? And now let's go to the mucus. The mucus, we said the mucus only has predominant DSG3, and because of that, the dysfunction of the DSG3 will cause a separation in the basal layer. So that is why in the pemphigus vulgaris, which only targeted DSG3, we have intact skin, while separated erosion of the mucosa. So this is the scenario number 1. Now let's move on to the next one. If the pemphigus vulgaris has an autoantibody against not only DSG3 but also 3 plus 1, both are involved, then what will happen? The DSG1 IgG will destroy this green DSG1, and the DSG3 antibody will destroy this DSG3. So nothing to compensate. Then we have a lesion blister, which we see them in the clinical photo. And similarly, the mucosa, there is nothing to compensate, and there will be mucosal erosion. So here is the situation in the PV with the DSG3 and DSG1 involvement. But in the pemphigus foliaceus, it only has anti-DSG1 IgG. So the DSG1 in the skin will be destroyed. And remember, the DSG1 cannot be compensated by DSG3, so there will be a separation. And because the DSG1 is mainly heavy on the top, so the separation will be at the superficial, at the granular layer. That is the reason. And in the mucosal lesions, because the DSG1 is only a minor component of the DSGs in the mucosa, so we still have an intact DSG3 to protect the integrity of the mucosa. That's why there is no mucosal lesion. I hope now it makes sense. Okay, now I think we can quickly go through the comparison PV and PF. For the PV, we have a DSG3 or DSG3 plus 1. For the PF, we have the DSG1. And the separation of the PV is suprabasal layer. In contrast, the PF is at the granular layer, subcorneal. The PV has mucosal involvement. PF does not. The PV, because the blister wall is thicker, has multiple layers of keratinocyte, it will be more flaccid. In contrast, the PF, since it's so thin, you only have the crusted erosion. DF, both disorders are the same, are showing the IgG, IC3, and with a fishnet pattern. I hope the two disorders now they make sense. In my previous slide, I put the paraneoplastic pemphigus in both intraepidermal and subepidermal, but here let's skip it first, then we will come back when we finish some of our subepidermal. I will be back. Now let's move on to the subepidermal blisters. Let's talk about the bullous pemphigoid. The clinical presentation, it can be divided into the early and the late phase. In the early phase, there may not be any blistering formation. Instead, you see those urticarial-like lesions as shown here. And later, the itchy blisters start to show up, and the blisters are more large and tense. If you do that Nikolsky test, it will be negative. The commonly affected areas include the trunks and the extremities, and the location on the extremities are on the flexor surfaces. The mucosal involvement may be minor, and the individuals involved are usually older. Let's talk about the pathophysiology of the BP. The reason we got BP is the body is generating autoantibodies, including the IgG as well as the circulating C3, targeting against two important components of the hemidesmosome. One is the BP180, the other one is the BP230. The BP180 is the major antigen, and the BP230 is not that important. It can also be targeted, but to a lesser extent. Because of the damage to the hemidesmosome, there is a tendency to separate between the epidermis and the dermis. Before the separation really starts, we will have urticarial phase, just like we said, the skin can just look erythematous and urticarial. At that phase, if you perform the biopsy, you may see no separation, but only eosinophils infiltrate and with some papillary dermal edema. Not very specific, but remember, if you see a very old individual, biopsy is for question mark urticaria, and you see tons of tons of eosinophils, you should think bullous pemphigoid in your top differential diagnosis. And later on, there will be a true separation between the dermal-epidermal junction. You will see there is a separation filled with eosinophils and neutrophils. That is a very characteristic feature for the bullous pemphigoid. Here is the BP180 and BP230. So what is the direct immunofluorescence study? It will show linear deposition instead of fishnet. You can see it demonstrated here, a linear. And the linear demonstration of IgG C3, this is not super characteristic, but in real life is almost certain this is a bullous pemphigoid. Why I say it is almost certain is because there will be another linear IgG DIF. We will talk about that in a later slide. Now, we are back for the paraneoplastic pemphigus. In the paraneoplastic pemphigus, the lesions can show polymorphic features, and from the blister disorder and erosions, as we can see in the pemphigus vulgaris, it can also show erythematous macules, papules, and plaques, as we can see in the urticarial phase of BP. It also can have the mucosal involvement, just we can see in the PV. And usually the patient, as the name implies, can have some systemic underlying malignancies. And the commonly associated malignancies including the non-Hodgkin lymphoma, CLL or CML, or the Castleman disease, thymoma, as well as some sarcomas. In the entities we talked about, the PV or the BP, usually the body only generates one group of autoantibodies against either the hemidesmosome or desmosomes. Instead, this paraneoplastic pemphigus, it can generate a whole lot of antibody against not only one but both of the hemidesmosome desmosome structures. As the arrows depicted here, you can see the antibody can mainly target those structures including the desmoglein, the desmoplakin, the BPAG1 aka BP230, as well as plectin and a lot of other things. And because of the involvement to both desmosome and hemidesmosome, the clinical presentation can have an overlap. Before we're looking at the histology, we can look at the picture on the right, which is showing the direct immunofluorescence. Either IgG or C3 will show this pattern, which has both a combination, both of fishnet as well as the linear IgG and C3, just like you put two pictures of PV and BP together. And because of that, we histologically can see those combination. We can have features of PV, a feature of BP, as well as the EM. Why there is a EM? That is because the mixed auto antibodies will recruit all the lymphocytes to come here, and the lymphocyte will generate a band-like infiltrate to resemble the erythema multiforme. Okay, we have finished that crossover BP, PV, and EM. Let's go back to the category of subepidermal blistering disorder. The next disorder in this category is the dermatitis herpetiformis. And pay attention to the name, even there is a herpetic, but actually is not associated with human herpes virus. People put this name, herpetiformis, basically means it looks like a herpes or herpes-like dermatitis. And the skin, it will present as multiple vesicles as well as papules. And the common locations are the extremity and particularly the extensor surface. Do you still remember I mentioned For the flexural surfaces, what was the disorder? I hope you said that is bullous pemphigoid. And the knees as well as elbows are the commonly affected site as shown in the pictures. It can be very sporadic, and the patient is complaining of itching and scratching. Instead of older individuals in the BP or the PV, the DH, dermatitis herpetiformis, usually affects younger individuals with Northern Europeans descendant, and Asians, African Americans are less commonly involved. And also it is associated with the gluten sensitivity or celiac disease. The patient may have some asymptomatic or symptomatic intestinal discomfort. That is the association. In terms of the pathophysiology of the dermatitis herpetiformis, it is the autoantibody IgA against the transglutaminase, which in abbreviation TTG. And the IgA antibody will form an immune complex deposition in the dermal papillae. That is the most common located area of the deposition. And because of the immune complex, it will attract all the inflammatory cells to come here, and those cell burst released all those MMPs and destroyed this basement membrane, and causing a separation or forming a large blister. So that is the pathophysiology. Histologically, we can see there is a subepidermal blister, and the most common inflammatory cells are the neutrophils, and you can see the neutrophils in the dermal papillae. Sometimes you can see eosinophils as well, but it's mainly eosinophils. Now let's look at the direct immunofluorescence in the dermatitis herpetiformis. And instead of a linear deposition, and this time the deposition is a shape of granular. You can see there is a granular deposition, and more interestingly, the granular deposition is mainly the IgA. And remember, the IgA can recruit the neutrophils. That is the feature of IgA. And the location is usually at the dermal papillae. And that is also the reason you see those neutrophils. They are very heavy in the dermal papillae area. The next disorder is somewhat connected to the one we just mentioned, the dermatitis herpetiformis, but it's actually a different entity. It's the linear IgA bullous dermatosis. In abbreviation, we call this LABD. The skin has a very unique presentation. Instead of only the bullous disorder, it will have an annular shaped lesion. You can see as here, all those annular shaped lesions. They can fuse together, have those grouped vesicles and the bullae. Commonly affected locations are the trunks and the limbs, and are very itchy. The oral mucosal involvement is very common. And interestingly, this one has a bimodal age distribution. It can affect those kids, as the picture shown, probably a baby, and also some adults as well in their 60s and 65. In the linear IgA bullous dermatosis, or LABD, the pathophysiology is all written in these names. And you can see it has IgA as the antibody. Linear basically means there is a linear distribution, and where is linear in the skin, which is the dermal-epidermal junction. So it's a very self-explanatory, and helps us to understand the disorder, not only the name but also the DIF result. The targeted antigen in the basement membrane is mainly the BP180 or the products or portion of the BP180. And here is the LAD1. If the patient is having an adult onset, sometimes there can be a particular reason. Most common reason are the usage of medication. And among all those medications, the vancomycin is notorious for inducing the LABD. Other commonly seen medications including the penicillin, the ACEI, those pressor medications, and the NSAIDs. The histology it can be very similar as the dermatitis herpetiformis, which we can see the subepidermal blister with the neutrophilic infiltrate. In the real life, the LABD and the DH, they can look alike, very much alike. But in your exam, if they are giving you the neutrophils only located at certain papillae, you should think DH. If you see more extended separation plus band-like neutrophilic infiltrate, you should think this LABD. But again, in real life, you need to see the direct immunofluorescence. I hope you remember DH is IgA but granular. LABD is IgA and linear. That is the difference. And this is just a repeat about what we have talked about. You will see the linear IgA at the basement membrane. It's very self-explanatory. The next disorder is the epidermolysis bullosa acquisita, or EBA. The EBA in the clinical is quite rare, and it also presented as itchy blisters. They can be large and very tense. If you look at the picture, I can tell you it really resembles bullous pemphigoid, and usually it is can be associated with some trauma-prone areas, and also has mucosal involvement. In older adults, may have a scar of the healing of the lesions. Sometimes it has association with other systemic disorders such as ABD and multiple myelomas. For the EBA, the pathophysiology is the body is generating autoantibody IgG against type 7 collagen. The type 7 collagen is a component of the anchoring fibrils. The location is here. You can see instead of the BP1 230 and the BP180 on the top, I hope you remember those are the two antigens for the bullous pemphigoid. This time the IgG is targeting against the type 7 anchoring fibers. So that is the targeted location. The histology is we have the subepidermal vesicular formation. Usually in the EBA, the inflammatory infiltrate is not that prominent, not as the BP, but sometimes you can see some cell-rich EBA as well. So basically, I'm saying that the histologic features may be indistinguishable from the BP. You may say, oh, the separation is different. One is at the top, one is at the bottom. Why they look the same? That is because the hemidesmosome is so small, and a separation you cannot easily tell, right? Here is the direct immunofluorescence. You can see the linear deposition of the IgG along the basement membrane. It is very similar as the bullous pemphigoid. One little feature may help you, give you a hint, is that if you have both IgG plus C3, that is more likely to be a BP. And if you only have IgG and negative C3, that is more aligned with the EBA. But in real life, if you see this pattern, it's almost certain it's a BP, because the EBA is much more rare than the bullous pemphigoid. But we cannot just tell to make the definitive diagnosis based on which one is more rare, right? So how can we make the definitive diagnosis? Is we use a special technique, we call that salt split test. So this time we talked a lot about the ancillary test. We talked about the DIF test. Now it's a salt split. This is to explain why and how we perform the salt split skin test. And why we perform it is because there are different types of subepidermal blistering disorder. They may have similar histologic findings and the DIF. And particularly I'm saying the BP and the cell-rich EBA, they can look alike, both under the histology as well as the DIF. So how can we separate the two apart? Is we can perform this test. And the technique is we incubate the skin in 1 mole the salt water for 48 to 72 hours to induce a split at one particular location, which is the lamina lucida. Where is it? It's actually here. So let me turn on my pointer. So you can see the BPAG1 and BPAG2, they are located above the lamina lucida. In contrast, the type 7 collagen is located below this lamina lucida. When we incubate the skin in this concentration of salt water for this period of time, there will be a split at the lamina lucida. And after that, when we have artificial split, then we perform the direct immunofluorescence. Of course, we can do indirect immunofluorescence as well. But for DIF, we can see where the autoantibodies are located. That is a very smart way to tell them apart, right? So here is the demonstration. When we have a roof pattern, means the roof means the BP230s, and that is more aligned or compatible with BP. In contrast, in this picture, if you have a floor pattern, means probably the antibodies are targeting those fibrils, which is more compatible with EBA. That is very unique finding, or very diagnostic for the salt split skin test. And here is the demonstration. I use this picture to help me understand which is which. And this probably someone tried to copy the idea from the movie Up, and they bind those balloons on top of the roof and try to elevate this house from the earth. So BP, B stand for balloon, is at the roof, and E stand for earth, is at the floor. So that is how I remember. I hope it will be helpful for you as well. Next entity is the Porphyria cutina tarda, or the PCT. The skin usually presented as multiple bullae and vesicles, and the common location is the sun-exposed area, and such as the back of the hands and the forearms, as the picture showing here. You can see those blistering disorders. And the mucosal involvement are rare. I think some of the reason is due to there is no solar damage to the mucosa, and the common affected individuals are in their adulthood. The photosensitivity is one of the features of the disorder, and the patient may present as the dark urine. The etiology for the PCT is that the patient is having a reduced activity of a particular enzyme called uroporphyrinogen decarboxylase, or for short we use UROD. Decreased the function of that enzyme will cause increased or accumulation of this uroporphyrins accumulated in the skin, and that accumulation will further damage the basement membrane layer. So that's why we will have a separation at the subepidermal location, forming this subepidermal vesicle. And the inflammation usually is very minimal, and the dermal-epidermal junction, you can see it shows very rigid dermal papillae, and some people describe this one as the festooning. Here is the festooning. Also, sometimes you can see those basement membrane zone-like material in small fragments in the epidermis as well. But this picture is very characteristic for the PCT. Also, you should see some solar damage at the background as well. In terms of the direct immunofluorescence result, this is quite unique. Not only you can see there is accumulation of IgG and IgM at the basement membrane zone, but also you can see papillary vessel with those accumulation of IgG and IgM as well. It's very characteristic, and you should remember that. All right, now congratulations, you have finished the most commonly seen blistering disorders in Dermpath. Now let's do this quick summary. So first, let's look at the BP. We said the BP should have a linear IgG and C3, and the split area should be at the roof. Remember, B stands for balloons, and the Western blot is to detect the antibody in the skin, in the bloodstream, which we should be able to find the BP180 and the BP230, in which the BP180 is the main target. And let's move on to the second column. The second column is showing the EBA. In the EBA, it should have also a linear IgG, and the C3 is much less commonly seen as it in the BP. And the split skin test, you should see that at the floor. Remember, E stands for Earth. Earth is as the floor. And then the Western blot will see the 290 KD, which is the type 7 collagen. I think remember the type 7 collagen or the fibrils should be enough. You don't have to remember this 290. And let's go back to the 180 and the 230. In another name, the BP 180, also known as the BPAG2, BP 230, also known as BPAG1. I don't know, people should just simplify all the terminologies, I think. And we will skip this bullous lupus and go to the linear IgA. And as we know, the linear IgA implies the DIF is having the linear IgA at the dermal-epidermal junction. And particularly, we see that pattern. We don't have to do further tests to make the diagnosis. And we don't do the salt split. We don't do the Western blot. We make the diagnosis of linear IgA. But remember, this one should have the BP180 as the main target. Another one is the product of the BP180 is the L81. And lastly is the DH. DH also has the granular, is also have the IgA, but this time it is the granular. And that is very unique. You don't have to do further step to confirm the diagnosis. So that is a summary of the blistering disorder. Next, I will talk about those inherited disorders, and mainly the disorders can mimic the blistering disorders, including the Dairy-Ace disease, Haley-Haley disease, as well as the Grover's disease. The first disorder is the Dairy-Ace disease. It has another name of Dairy white disease or keratosis follicularis. Histologically, you can see in the picture there is a acantholysis, means the cells are separating apart. It gives you the impression of the pemphigus vulgaris, right? Has a separation above the basal layer. But it is not a confluent separation. It is more focal acantholysis. And other than that, you can see some very particular unique looking keratinocyte. Some of them look very condensed, give you the impression of grains or corons, those French names. And that is we call dyskeratosis. Clinical presentation is also separate apart from the blistering disorder. And this time it is presented as multiple keratotic papules on the surface. And some of the lesions, they look more like crusting and scaling without a real bullous formation. So that is a unique finding, both histologically and clinically, telling it apart from the blistering disorder. Also, when you are performing that direct immunofluorescence study, you will find it to be negative and also further separated apart from the autoimmune blistering disorder. And why this happened? The reason is that there is a dysfunction in the molecule called ATP2A2, which is inherited. And that is one of the molecule will regulate the function of the hemidesmosome. When there is a dysfunction in the hemidesmosome, that is the time we have the separation. So the bullous vulgaris is having a function because of the autoantibody, and this is inherited disorder, so Dairy-Ace disease. And how I remember this is Dairy-A disease has Ds, so it is more deep, suprabasilar, dyskeratosis, the chorons and the grains, and double 2, which is the ATP 2 and 2. So that is how to remember diarrhease disease. The next disorder is the Hailey-Hailey disease. It has another name as the familial benign pemphigus. So it's rare, and it was first identified by two brothers, both with the last name Hailey. So that is why it has a name Hailey-Hailey disease. So as the name implies, it is a benign but a familial and a clinical presentation like a pemphigus. Histologically, you can see there is a separation. It's more extensive separation. You can see here resemble a dilapidated brick wall. So this is a picture of a Great Wall in China. Maybe has a few hundred years of age, and it start to separate apart, dilapidated brick wall. So here is the higher magnification to show this extensive acantholysis at all the levels. In comparison with the diarrhease disease, the dyskeratosis is lessly seen, and if we perform that direct immunofluorescence, it is also negative, since it is a dysfunction in the ATP2C1 molecule, which is causing another dysfunction in the desmosome. There is no eosinophils, so even if you are thinking this could be a pemphigus, no eosinophils will give you a hint. Probably this is the Hailey-Hailey disease. Another feature I did not put it here is that usually there is a separation, then there will be some proliferation of the epidermis. So sometimes you can see the pseudoepithelial omatous hyperplasia. That is something you can see in Hailey-Hailey disorder. And some people think it's hard to remember the 2C1 and the 2A2. I have already told you that for the diarrhease disease, I use that 3Ds. And for Hailey-Hailey, people invented this. I want to see Halley's comet one day. So 2C1 is here, Hailey-Hailey disease, right? And here is a comparison between the diarrhease and versus the Hailey-Hailey disorder. For the diarrhease, we see the distribution as the separate distribution involving the back, the chest, the head and neck location. Mutation 2A2. Histology, we have both acantholysis plus dyskeratosis. Remember, this is one of the Ds. Mucosal involvement is yes. For the Hailey-Hailey, we have intertriginous area, and the mutation is 2C1. I want to see Halley's comet one day, right? And the histology is acantholysis, but less dyskeratosis. The mucosal involvement, Hailey-Hailey, is no. The diarrhea is yes. The next disorder is actually not inherited disorder, but since people always confuse the disorder, Grover's disease, with the diarrhea and Hailey-Hailey, so I put it here for comparison. So instead of those crusted in the diarrhea and in the flexure area, such as armpit, as we've seen in the Hailey-Hailey's, the Grover's disease, the distribution is usually in the trunk and in the older individuals. And the clinical presentation, instead of the big plaques or patches, it usually presented as multiple papules, sometimes crusted papules. And the histology is showing the small foci of acantholysis, as the picture shown here. You can see it is very focal. On the left, there is no separation. On the right, there is no separation, only exists at the center. Sometimes we even need to cut multiple deeper levels in order to find this very focal change. So focal acantholysis is a feature of the Grover's disease, and you need to correlate with the clinical presentations as well. As the picture showing here, you can see multiple small papules crusted on the trunk. That is compatible with Grover's disease. The dyskeratosis, you can see them, but not as prominent as the diarrhease disease. And in some areas, you can only see the spongiosis. And the DIF, of course, it is not autoimmune disorder, so it is DIF negative. Very common, much more common common than the diarrhease and the Haley-Haley disorder. Let's quickly go through the skin-associated inherited syndromes. The first one is the Muir-Torre syndrome. We know that is a type of the HMPCC. We learned that from our GI pathology. But in the skin, it can have different skin tumors associated with that, such as the keratoacanthoma and sebaceous tumors. It can have both benign and malignant, such as the sebaceous adenoma, specioma, sebaceous carcinomas. So whenever we have a younger person with the sebaceous adenoma, specioma, upon request, we can perform the PMS2, PMS6, those type of the mismatch repair gene test. We can do that in immunostain. And the second one is the P10 related disorder called Cowden syndrome or Cowden disease. So people remember this as how do cow say? The cow will say moo. So remember the trichomoniasis is the Cowden's disease. The third one is the Birt-Hogg-Dubé. It's super important in the skin path. So the BHD syndrome is associated with multiple fibrofolliculoma, which is in the same spectrum of the trichodiscoma, or some people believe they are the same thing. So it is associated with the FLCN gene and encodes protein called the folliculin. It is also associated with systemic renal cell carcinoma and can cause some spontaneous pneumothorax. Next disorder is the Carney complex. Associated is the PRKARIA, and the mnemonic for it is the LAMB, stand for lentigens, atrial skin myxomas, and blue nevi. And another Carney you also need to remember very well is the Carney's triad, which is composed of the gist, pulmonary, chondroma, and the paraganglioma. The next one is the Gardner syndrome. The Gardner syndrome is APC gene related. You can have multiple epidermoid cyst, pilometricoma change. So if you see a person with multiple pilometricoma, then you should think this syndrome maybe get the patient to have an APC gene tested. Also, the fibroma is associated with Gardner syndrome. Next one is also important in this Dermpath is the Brooks-Spiegler syndrome. Affected gene is the CYLD. The patient may represent multiple trichoepitheliomas on their face and head and neck region. And because of the multiple, maybe hundreds or even thousands of the trichoepithelioma on the entire face or the scalp, one of them someday will break bad, become a basal cell carcinoma or trichoepithelial carcinoma. And also it is associated with some sweat duct tumors such as the spiroadenoma and the cylindromas as well. Next one is the basal cell nevus syndrome or Gordon syndrome. Affected gene is the PTCH, and it can have multiple basal cell carcinoma, palmoplantar pits, odontogenic keratocyst of the jaw, as well as the medulloblastoma. And the last but not the least is the tuberous sclerosis. Affected genes are the TSC1 and the TSC2. When you are doing your neuropath rotation, you should know the SIGA is associated with the tuberous sclerosis, and heart. In the heart is the rhabdomyoma associated with the TS. And in the skin, the patient may represent multiple angiofibromas on the face near the nose region. And in summary, those are the most high yield. If you are in your exam, you see they're asking you some syndromes you are not completely familiar, I would guess you should choose autosomal dominant, because in your general AP and CP board, all the skin-related inherited disorders, they are all autosomal dominant. There are definitely a few autosomal recessive and XR, but again, for your AP-CP, they are all AD. I think that's enough. Great. As we conclude this lecture series, I finally want to take a moment to express my gratitude to all of you for your attention. Your engagement have truly made these sessions enjoyable. I'm really happy. Also, I would like to extend a special thank you to Dr. Bala for her trust. I'm just a first year junior attending, but with her trust, I'm honored to have this opportunity. And third, to all the residents, I just want to encourage you to continue learning and growing in your medical careers at LSU. I've been there as LSU alumni. I know that LSU may not always have the biggest name, but to me, I firmly believe that the LSU residents have access to the best resources and the best teachers available. I like everyone at LSU and I miss everyone at LSU. I know your dedication and hard work will undoubtedly lead you to success. And lastly, if in the future you have any questions or need further classification on any of the Dermpath topics we covered or we haven't covered, please do not hesitate to contact me. I'm always here to support your learning journey. And thank you all once again, and I wish all you the best of luck in your future endeavors. Thank you.